Okay, so the scenario today is that you are sitting in the regular eye OPD and a patient presents to you. This patient is a young patient. He has presented to you with the unilateral cataract. So, what are the things that you will think about it? You will think about trauma. First of all, we will think that this unilateral cataract is because of trauma. But what if the trauma has been ruled out? There is no history of trauma. What will be our diagnosis then? We'll think about something else. Okay, in that scenario, we'll have to look in the eye again and see if we can find heterochromia, if the eye color of the eye which has cataract and the eye which is not having cataract is same or different. We'll have to see if the color is the same, if the color of the iris is same or different. So if we are able to find heterochromia, what will that mean? That we will be able to narrow our diagnosis to one particular disease that's called Fuchs Hetrochromic Iridocyclitis. So what exactly is Fuchs Hetrochromic Iridocyclitis? This was presented by Ernst Fuchs in 1906 when he studied 38 patients with the symptoms of cataract, cyclitis, and heterochromia. So he thought that the Fuchs Hetrochromic Iridocyclitis was mainly because of cataract cyclitis and iris heterochromia. But we later found out that we have some other symptoms too. And these constellation of the symptoms make up Fuchs Hetrochromic Iridocyclitis. What other symptoms are? They have unilateral anterior segment inflammation, which is low grade, and it imparts Keratic Precipitates on the cornea. Other than that, they have prominent iris and angle vessels. And these vessels are liable to bleed whenever the anterior chamber is accessed. For example, during a cataract surgery. And this is called Emsler's sign. We will study about it later. Now we have to think what exactly caused this kind of problem, this disease. So we have to look into etiology. Fuchs presumed that this was caused by some noxious stimulus. And what exactly was this noxious stimulus? He tried to narrow it down to some viruses and other noxious stimuli, but the exact etiology, they found out that it was unknown or it was multifactorial. So later in history, different theories were proposed, and we have to see how much these theories stood the test of the time. The first theory was that this happens because of sympathetic dysfunction. Sympathetic dysfunction leads to decreased innervation to the stromal melanocytes, and this will also lead to breakdown of the vessels, and the vessels will then happily allow WBCs to come and get the iris inflamed. But in Horner's syndrome, as we know that there is decreased sympathetic stimulation of the iris, only it was found that 1.4% of the Fuchs Hetrochromic Iridocyclitis were found in the Horner's syndrome. So this is not really a strong correlation, so this theory was rejected. Another theory was that because in Fuchs Hetrochromic Iridocyclitis, different chorioretinal scars are seen, and these scars resemble the toxoplasma scars, like chorioretinal scars. For that, a study was performed and it found no significant clinical associations. Another theory was that HSV or chikungunya virus caused this because viral DNA and RNA respectively were found in the aqueous humor of the Fuchs patients. But this study was also limited to some case reports and it could not be generalized. Another theory was that CMV virus or RV virus used to cause this kind of syndrome, and this was pretty powerful because 16 to 24% of Fuchs in Asia were uh, caused because of CMV viruses, and a study was performed in which out of 35 Fuchs heterochromic iridocyclitis cases, 15 were found positive for the CMV DNA. So CMV virus was found mainly the culprit in Asia. What about the Western countries? For Western countries, we had the RV virus, and this was strongly correlated with the Fuchs because 63 European patients with Fuchs heterochromic iridocyclitis were all found with the intraocular antibody against the RV. So yeah, this is how we narrowed it down to CMV and RV. Okay, so now we have to see how do we diagnose the Fuchs heterochromic iridocyclitis. It's mainly on the physical examination that we find what are the signs which we can pick. Mainly this, because this disease is asymptomatic, we are able to find it later in the stage when the cataract has developed. So mainly the presenting complaint becomes cataract. Okay, presenting complaint is either cataract or vitritis. So next, okay, first of all we'll have to study the iris heterochromia. Why is iris heterochromic? Because one side of iris, for example, this is our normal eye and this is the affected eye. The affected eye, the iris of the affected eye becomes atrophic. That is how it is turned into hypochromia. Then we have low-grade iridocyclitis, which will not respond to steroids. We don't need steroids for that. We don't need this this iridocyclitis will not form posterior synecdoche. However, it will have mild vitritis with stringy vitreous. And even in this vitritis, there will be no cystoid macular edema. Next up, we have Keratic Precipitates. Keratic Precipitates are the fine stellate interconnected by fibrin bridges, and these are diffusely present on the endothelial surface of the cornea. Next up, we have cataracts. Cataracts really occur high in frequency in the Fuchs heterochromic iridocyclitis, and mainly the presenting complaint is cataract. So 3/4 are posterior subcapsular cataract, and the cataracts, when they are not giving history of trauma or steroids, we'll definitely have to think about the Fuchs heterochromic iridocyclitis and see if the patient has heterochromia as well. Then we have iris nodules. Iris nodules are kipis and busakas, but we just have to differentiate another type of uveitis where these are also common. So we'll have to keep the granulomatous uveitis as differential diagnosis because these nodules are also found in that kind of uveitis as well. After that, we can have the iris crystals. These are nothing but the aggregates of the immunoglobulins. These are small refractile crystals, and we call them the Russell bodies. Then we have iris rubeosis. Rubeosis means the neovascularization of iris. Now what happens is that the new vessels on iris will eventually block the angle and will lead to glaucoma. And if the cataract surgery is performed in the situation of iris rubeosis, because the neovascularization has already blocked the angle, we can see that whenever the anterior chamber is accessed in the cataract surgeries, we will see this bleeding signs in the for example, if this is the cornea of the Fuchs patient, and this and the neovascularization is present all around the angle, what happens is that if we try to go poke this cornea from here, during cataract surgery, we do paracentesis. If we try to enter the anterior chamber from here, the blood vessels will bleed from the opposite direction as the pressure affects. We'll have a picture, we'll see later that. Okay, even if the cataract surgery is not being performed, and the pressure from gonioscopy or applanation tonometry can also cause the bleeding from these new vessels. Okay, next finding is a chorioretinal scar. The chorioretinal scars are more common in the toxoplasmosis, and these are prevalent in this type of uveitis. But these really indicate that we have to look at other differential diagnoses as well. Okay, so how do we diagnose this syndrome? We diagnose it on the constellation of the clinical signs that we find, and workup is only done to exclude the other causes of uveitis. Okay, on differential diagnosis, we have to keep HSV and Poncer-Schlossman syndrome. Okay, what happens in HSV is that we have atrophy of iris and diffuse gaze. So if we are seeing atrophy of iris and diffuse gaze in Fuchs Hetrochromic Iridocyclitis, we also have to think, or we have to exclude HSV. The next syndrome is the Poncer-Schlossman syndrome. And what happens is that this resembles really close to the Fuchs Hetrochromic Iridocyclitis because it has heterochromia, anterior chamber inflammation, gaze, and IOP is also raised. So, but how can we differentiate is that because this responds well to steroids. Okay, now let's talk about the management. First, because this is cyclitis, iridocyclitis, so definitely wherever itis is present, there is inflammation. So for inflammation, what we usually do, we use steroids, right? But this is actually really low grade inflammation, and the inflammation is due to the blood aqueous barrier breakdown, and the leakage of cells and proteins occur from there, and it is not because the inflammation itself is causing the immune response. So the steroids are not used in this case, and steroids are only used to differentiate it from the Poncer-Schlossman syndrome, which actually responds to steroids. Then we have cataract, and for cataract the easy answer is that we can do phacoemulsification. Phacoemulsification with intraocular lens implant really gives a good prognosis. Then we have for vitreous opacification, if the floaters are seen in front of the eye and they are really disturbing the vision, we can do pars plana vitrectomy. It also has a good prognosis. Then comes the problem of glaucoma. What happens in glaucoma is that glaucoma can be open angle when the aqueous outflow is obstructed because of inflammatory debris and nodules, and it can be a closed angle glaucoma when there are anterior synecdoche formed, or there is phacolytic glaucoma, or there is neovascularization of iris, or it is steroid induced. So for all these glaucomas, what we do is that we do trabeculectomy or glaucoma drainage implants. They have variable prognoses, but this is all that we can do. Now let's move to our presentation mode. This was the actual kind of PowerPoint presentation that I had to make, but I was more comfortable on the paper, so I chose to do the explanations there and then show the pictures here. So this is the first slide of the Fuchs Hetrochromic Iridocyclitis, and this is the actual presentation of this is the actual case that I have seen in the clinic of Professor Dr. Ejaz Latif, and this was the patient on which he explained me Fuchs Hetrochromic Iridocyclitis. So as you can see that this is the left eye and this is the right eye. The right eye is not having any sort of anomaly and cataract or hypochromic iris or stuff like that, whereas this left eye we can literally just differentiate it because they are placed side by side. Although the light in left eye is more than the right eye, but still we can differentiate the hypochromic iris and the cataract which is present in the center, mature cataract that's present in the center. So over here, the left eye is the Fuchs eye, and this is the highest heterochromia that I found on YouTube. You can see that this particular eye is heterochromic and also has cataract. Okay, these are the small capes which we can see on the cornea, and this is the Emsler's sign from Dr. Hassan Khalid's video of the phacoemulsification. The point of entry of the instruments was this particular point, and the bleeding is from this opposite direction. So this is how we are able to see. This is the typical Emsler sign presentation, where you enter from one side of the eye, you do paracentesis of the anterior chamber from one side, and the bleeding occurs on the other side as a pressure effect. So this is it. Thank you.